Hi, everyone. Welcome back to another episode of Inner Ear Secrets, the podcast where we dive into all things audiology. I'm Veronica.
And I'm Tiffany. Today we'll be exploring one of the most common and confusing symptoms we see in clinic, dizziness. When a patient says they feel unsteady or the room is spinning, it can be quite tricky to figure out what's actually going on. Is it coming from the inner ear, the brain, or maybe even the neck and muscles?
Yep. Let's break down how a vestibular or balance assessment look for us audiologists. We start with a hearing test, some history taking, asking about the symptoms of their dizziness, the duration, any triggers, and how often it happens. As audiology students, we're taught how to investigate vestibular dysfunction using a range of diagnostic tools. Tests like vHIT, VEMPs, Calorex, and Dixel pipe help us identify whether the issue is coming from the vestibular system. For example, vHIT tells us how the semicircular canals are working. They're the part of the inner ear that helps detect rotational, like when you turn your head very quickly. And VEMPs check how the otolith organs respond to linear movements, like going up and down in the elevator or when you move back and forth. From these vestibular testings, we look for things like vestibular hypofunction, BPPV, or even central red flags that may need ENT or neural referral. But what happens after the diagnosis? That's where vestibular physiotherapy comes in.
In this episode, we'll be chatting with Laura Power, the principal vestibular physiotherapist and the founder of the Vertigo Co, who works closely with patients experiencing dizziness and balance issues. We'll cover how to spot key clinical clues, what actually happens during vestibular rehab, and how we can work together to support our patients with persistent vestibular issues. Hi, Laura. It's great to have you here with us today.
Hi. Thanks for having me. It's nice to meet you all.
Before we dive into the details, could you tell us a bit about your background and what inspired you to specialize in physio?
Yeah, so I've been doing vestibular physiotherapy for about 15 years now. I sort of fell into vestibular physiotherapy as a new graduate. My first rotation was in the Falls and Balance Clinic at Bendigo Health, and I just found a passion for it. My first observation of a patient with BPPV and seeing their nystagmus really captured my attention. My first course was in vestibular rehabilitation, and I've just sort of fell in love with it ever since. And I've sort of been doing that since a new graduate, so that was 15 years ago. Yeah.
Yeah. So, from your side, Laura, how would you describe the role of a vestibular physiotherapist, and what are some of the common symptoms or red flags people present with you when they come to see you?
So the role of a vestibular physiotherapist is to assess and treat people who are experiencing dizziness, vertigo, or balance problems related to the inner ear and brain. We're kind of like a vestibular detective, I suppose. So we look at how the vestibular system is functioning and then use targeted exercises really to retrain the brain and manage those symptoms better. That might mean reducing dizziness, improving balance, or helping someone feel steady when they move the head or moving in busy environments, for example. So we're not just treating the symptoms, we're addressing the root cause, whether that be BPPV, vestibular neuritis, vestibular migraine, persistent postural perceptual dizziness, for example, or something else entirely. Some of the common symptoms or red flags that people present with. So some of the common symptoms that can be vertigo or dizziness getting in and out of bed or turning over in bed, for example. So if it's BPPV, spontaneous episodes of vertigo. So if it's something like vestibular neuritis or vestibular migraine, for example. Feeling off balance in busy environments like supermarkets or shopping centres, for example. That's quite common in vestibular migraine, for example. Blurry or unstable vision when they're moving the head. Motion sensitivity or persistent sense of fogginess, for example. That's quite common. Many people describe they're feeling like they're walking on a boat, such as in Melder debarkment syndrome. Their eyes can't keep up with their head. In terms of red flags, these are some of the symptoms that are suggesting something more serious might be going on, and they always require medical investigation. So that can include things like sudden hearing loss, diplopia, so sudden double vision, a vertical nystagmus, so particularly downbeating nystagmus. So would that be when the patient's upright or in the Dixwell Pike position? So that's involuntary eye movements, either in the up or downbeating position. Facial weakness or drooping, slurred speech, sudden or severe unsteadiness or inability to walk, loss of consciousness or fainting, numbness or weakness in the limbs, a new onset severe headache, especially if it's the worst headache they've ever had. Some of these signs and symptoms are potentially life-threatening as a cause of dizziness. So such as stroke, for example. So they always warrant a referral to a specialist or even to ED, for example.
That's really such a clear explanation.
Yeah.
And it's really interesting to see how it overlaps with what we see in audiology as well. And your approach zooms in on the function. What are some of the most common activities people struggle with when they come to see you, especially with all the symptoms? How like they affect their daily life a lot. But what are some of the common activities that you usually see that you're like, oh, I just can't do it. I'm struggling with.
Yeah. So there's quite a few. Most of the common things people sort of report is things like difficulty walking in supermarkets, turning their head, turning over in bed, scrolling on their phone, for example. People often can't tolerate bending down, looking up, turning side to side. Things like patterned floors, for example, fluorescent lighting. Difficulty with visually busy places like shopping centres can be triggering. That's quite common in things like vestibular migraine or persistent postural perceptual dizziness. Everyday tasks like hanging out the washing, particularly things like BPPV, looking up and down.
Yeah.
Watching TV, even having a conversation in a noisy cafe. So migrainous sufferers have trouble with that. It can be difficult if you have a vestibular disorder. People often feel quite unsteady on their feet, like they're veering when they're walking, or have trouble with their eyes closed. So things like washing their hair in the shower, for example, can be difficult with people with vestibular disorders. So eyes closed tasks or walking in the dark, for example, can be difficult as well.
We have placements where we do the vestibular assessments, explain the findings to patients, and they refer to physio, but we don't always get to see what happens after. So, Laura, could you walk us through what a typical vestibular rehab session looks like?
Yeah. Absolutely. So a first session always starts with a detailed history, when the symptoms started, what makes them worse, whether they're constant or episodic. From there, we usually assess the vestibular system, doing things like an ocular motor assessment, so looking at how the eyes track. So things like spontaneous nystagmus, smooth pursuit, saccades, for example. A bedside head impulse test, so to check the function of the vestibular nerve. And that can be, so in our clinic, we've got things like the VestiCam, for example. A Dix Hallmark test and a supine roll test, so positional testing for BPPV. A motion sensitivity assessment, so looking at patients how respond to movement, whether they're sensitive to movement. A balance and gait analysis as well. And depending on what we find, rehab might include things like gaze stability exercises, for example. Keeping your eyes focused on a target while you're moving your head, for example, to retrain the vestibular ocular reflex. Habituation exercises, repetitive movements like turning your head side to side, 360-degree turns, bending down repeatedly. They're designed to gently expose the brain to movements that trigger symptoms so it can recalibrate the system and desensitize your body over time. Balance retraining on firm and unstable surfaces, for example. And if BPPV is present, we'll do repositioning maneuvers like the Epley, for example, or whether that be the barbecue roll or the Appiani, for example, to get the crystals out of the semicircular canal and back where they belong.
How long do patients usually need vestibular rehab? I'm sure it varies on the case, but could you give us a few examples of what the timeline looks for different conditions?
Yeah, it definitely varies depending on the condition, how long symptoms have been present, and how well someone's brain compensates for the disorder. But a general guide, a general rule of thumb. So for BPPV, some people dramatically improve after one session, okay? But especially if the maneuvers do work. But if there's residual dizziness or if it's recurrent, or some people have refractory BPPV, so it might take multiple sessions. So say 4 or so, and some balance retraining. So if some people have motion sensitivity after BPPV, they might take multiple sessions. The vestibular neuritis, for example, we generally give a guideline of around 6 to 12 weeks of targeted vestibular rehab. Vestibular migraine and 3PD, for example, these conditions often need longer, a more layered approach, so around 3 to 6 months or more. And they may require a multidisciplinary team, so particularly 3PD, for example, physiotherapy, psychology, like cognitive behavioural therapy and medication as well. Maldebarkment syndrome, for example, It's often slower to respond to rehabilitation and requires longer term rehab. So we often quote, around 6 months, for example. And we often use visual vestibular retraining, so things like the DIE protocol, for example. Progress is possible, but it's usually not quick.
As we start to wrap up, we want to ask, what do you wish more audiologists knew about vestibular physiotherapy and how we can work better together?
Yeah, sure. The main thing is recognizing that even if someone's vestibular function testing comes back normal, I think they may still hugely benefit from vestibular rehab.
Yep.
So, people with conditions like 3PD, vestibular migraine, or residual dizziness after BPV often don't have a detectable deficit on vHIT or calorics, but functionally they're often still struggling. Audiologists are really, very skilled at detecting and localizing vestibular dysfunction, and information is, really invaluable to us. And we often get the report, that might show a left-sided hyperfunction or confirmation of BPPV, and that does help us to tailor our rehab, really efficiently. But sometimes people don't have a deficit, and that doesn't necessarily rule out vestibular rehab. Better communication and co-management really help us to improve outcomes, working all together to achieve the same goal, by helping the person in front of us regain confidence, independence, and function.
Before we officially close, we're going to do a quick rapid fire round with you, Laura, for some fun and fast takeaways. First thing that comes in mind, what is one vestibular myth that you wish people would stop believing?
Sure. So, one isn't necessarily one word, but I'll give you like a quick and I guess that the dizziness means that you should stop moving. Okay, it's the opposite. So unless you're in
Yeah.
an acute BPV attack, avoiding movement that makes things worse. So the vestibular system really thrives on movement. So movement's the stimulus that makes the brain needs to recalibrate. So I think that people need to keep moving, even if
Oh,
yeah. So I think that's
Oh, that's interesting.
yeah, that's interesting.
so you need
I've
to
never.
keep
Mhm.
moving even if you're dizzy. Yeah.
We'll keep that in mind. And what is APPV in one word?
Treatable.
And what is the most under-recognized cause of dizziness?
I would say 3PD, so persistent postural dizziness.
Mm.
Comes after an initial vestibular event, but often lingers, so the brain gets stuck in a heightened state of alert. So people often get told your tests are normal, but they still feel off. So they still feel very off. It's very real and it's very treatable, so often with the approach.
Yeah.
And your go-to vestibular rehab exercise?
I would say habituation exercises. So especially things like 360-degree turns, walking, head movements, or repeated bending or looking up. Very simple, repetitive tasks that helps the brain retrain and get used to motion again. They're incredibly effective for reducing sensitivity with vestibular patients.
What is the one red flag that you would never ignore?
This was a tricky one, and I found it difficult to narrow it down to just one, but I'd probably say loss of consciousness. Okay, so someone blacks out or faints or loses consciousness, it's definitely not vestibular. Okay, so the vestibular system does not cause loss of consciousness. And that could point to something cardiac, neurological, or another serious medical issue that always requires urgent investigation. So any loss of consciousness, not vestibular. Yeah.
Yep. So, well, that's amazing. And it was super fun and insightful. Thanks so much, Laura. This has been a very informative episode. We got a lot of information, things that we didn't even think of before.
Yeah.
It's been so valuable hearing about the physio side of things.
And if you enjoyed this episode, don't forget to follow us on Spotify or Apple Podcasts. And we'll be back soon with more interdisciplinary episodes. But until then, this has been Inner Ear Secrets. Catch you next time.
Bye. Thank you, Laura.
Yeah.